My name is Dr. Luis Daluz. My subject in this presentation day is going to be laboratory testing during the massive hemorrhage protocol. I do not have anything to disclose. So we'll be talking about the minimum recommended testing, the minimum lab resuscitation targets, the processes for sample blood collection, the frequency of testing, the expected turnaround times, how we should be communicated by the laboratory of these test results, prioritization of tests, the use of viscoelastic testing, and we're going to be briefly touching about special patient populations. All the recommendations that will be cited today, they come from the expert consensus panel, which has been already published. So the minimum recommended laboratory testing will be the CBC, INR, APTT, fibrinogen level, electrolytes, ionized calcium, arterial or venous blood gas, and lactate. Of course, this is going to be adapted to the specific characteristics of each site, if it's a small or a tertiary care center, for example, and test availability. So, for example, we know that not in all Ontario hospitals, we have fibrinogen kits. And of course, clinicians may alter this list according to different patient populations. For example, if you have a patient with an end-stage liver disease, you probably will want to collect their liver function. So what are the minimum laboratory resuscitation targets? The hemoglobin more than 80, INR less than 1.8, fibrinogen more than 1.5, platelets more than 50, and ionized calcium more than 1.15. If you are using viscoelastic testing, then you're going to be using the thresholds already published in the clinical practice guidelines existing in the literature. For peripartum hemorrhage or post-cardiac surgery, the recommendation is to keep the fibrinogen level at 2 or more. So what are the processes for blood sample collection? The hospitals have to have their sample tubes in situ, so basically ready to go for the baseline testing and of course for the hourly subsequent testing. The ideal is to be organizing these sample tubes in bundles, and they should be properly identified and easily dispensed. This is to increase the awareness for the next blood draws. To have a process in place, it's very recommended by the panel to replace sample tubes. And an option, for example, would be attaching a sample tube kit to each MHP pack or cooler. So what are the minimum frequency of testing? So you're going to be doing your baseline testing on patient arrival, and then at minimum hourly, and this is also a recommendation from the panel, until the termination of the protocol. Of course, in smaller community hospitals, usually only baseline blood work will be ready prior to transfer. And again, of course, you will not be delaying transfer to wait for the next time point. And different approaches depending on the clinical scenario, for example, in pediatrics or in anticoagulated patients, may be adopted. So we created this chart, which basically demonstrates the lab tests, the required tubes, and you see that each color represents the Vacuum-Tyner color tube, and you have the minimum amount of blood that should be collected for adult and pediatric population, and if the test should be repeated hourly or just at baseline. So briefly addressing the expected turnaround times. Laboratories should have processes in place to prioritize performing and releasing tests. So one of the things that it's important, and we need to focus on that, is the time to blood sample to reach the laboratory. And this may, of course, increase the turnaround time. So the hospitals are expected to have a dedicated staff to transport the blood sample from the bedside to the laboratory. So an ideal turnaround time would be 20 minutes. Of course, each facility will be determining their turnaround time. And the TAT, the turnaround time, should be focused on quality assurance. So blood tests are ready. How the clinician should be informed. This, of course, should be done as soon as possible, and this should be done verbally. The communication should be done to all transfusion-related targets, so hemoglobin, platelets, INI, and fibrinogen. The abnormal results should be not delayed while awaiting confirmatory testing, and should be a verbal disclaimer that confirmatory testing is being conducted in the laboratory. And why to get these results quickly? Because this may impact clinical decisions. This may be helping mitigating risks of under and over transfusion, and help with correction of other electrolytic and or coagulation or metabolic abnormalities. If you are transferring your patient from your small hospital to a larger hospital, you're expected to send the baseline values with the patient. So which tests should we be prioritizing? Now, group and screen are very important because they are going to minimize the impact on all red blood cells and AB plasma stocks. At the same time, each facility or laboratory may define which tests are more important. This is going to depend on hospital or laboratory characteristics, the staffing, the availability of kits, and of course, as decided as per clinician discretion, according to different clinical scenarios. We are expected to switch to ABO group specific as soon as possible. This is basically to for all RBC conservation, and confirmation of ABO group before type specific units can be issued should be done. What about the use of viscoelastic testing? So this goal-directed therapy, which is basically represented by the thromboelastography and rotational thromboelastometry, they have been used in different perioperative settings to guide resuscitation. So it's a more precision medicine type of testing. And it's been used in trauma, cardiac surgery, and postpartum hemorrhage. In Canada, this is being used in a few large centers, basically because of logistics and cost problems. The transfusion parameters are difficult to define still nowadays because they have not addressed in randomized trials. Of course, if the center is using this type of testing, they are expected to establish their protocol and including the thresholds for transfusion that are based on published clinical practice guidelines. What about some considerations for special patient populations? Of course, ideally, would be to have a single protocol for all patients populations, basically to optimize compliance. But we will be tailoring, the protocol for specific settings. So, for example, in cardiac surgery patients, we know that the evidence for using viscoelastic testing is more robust compared to the other settings. So they are said to reduce risk of major bleeding. So if you have access to viscoelastic tests, you should be using them. And the samples for the viscoelastic testing, they should be collected as per each facility guideline on this type of testing. What about for obstetrical hemorrhage associated to trauma? So we know that fibrinogen is very important. So fibrinogen samples should be prioritized, collected early in the resuscitation process and repeated hourly. Remember that the level of fibrinogen to be kept in obstetrical hemorrhage is more than 2. For pediatric populations, CBC and group and screen are prioritized. If there are limitations for volume collection, we have to decide what types of tests can be bundled so that we are able to decrease the amount of blood collected. Blood glucose, it's an important test here because it's a predictor of outcome in brain injury in this population. Electrolytic abnormalities, also important, and magnesium together with the calcium are important because they are commonly abnormal, as I mentioned, and the magnesium can exacerbate hypocalcemia. Minimal volume will depend on the type of analyzers and systems at each facility. As much as possible, we should be avoiding intraosseous samples and using capillary testing instead, or capillary collection instead. But intraosseous can be used to group and screen collection. So I'm finalizing my presentation here. Thank you, and I am happy to answer any questions.